let's start with the hematology, second class. We have discussed the thalassemias and microcytic anemias in the previous classes actually. Now, after a long gap, we are now with the hematology second class. It's a sickle cell disease. I just want you to start with these things. That sickle cell diseases, how the crisis questions mostly came. So we need to just go through these things. Look, how we can describe the sickle cell disease. Okay, so it is a disease which results from, you all know that single glutamic acid is just replaced by valine at position of 6. All of us just know by reading these things. But what we need to know actually, the disease itself, when it is symptomatic, when it is asymptomatic, mostly. Actually, it is a homozygotes, autosomal recessive. You should first remember that it is a autosomal recessive disease. So whenever there is autosomal recessive disease, we should go for thinking about that there should be 2 genes in the beta chain abnormal, like SS. So hemoglobin SS is the disease one. And if there is only 1 abnormal gene, beta chain abnormal, there is 2 abnormal, but 1 abnormal beta chain, there will be AS. So sickle cell trait. So how we call the double S is sickle cell disease, as there is autosomal recessive, 2 abnormal genes should be present. And another one is AS, that is only 1 is the abnormal one. So it is very easy. We have no question about this actually. We need to go for the crisis and complications mostly. Why this pathology happened? We need to know. Look, when hemoglobin S is deoxygenated, the molecules hemoglobin polymerize to form a crystalline structure that is tectoids. So it's just a pathophysiology. Actually, the red cell membrane is biconcave normally, but at this moment, for this substitution, it present as a sickle-shaped cells. So whenever the cell does not maintain its feature, so there will be some changes in the surface area. Like if it's sickling like moon, so there is some problem with the oxygenation of the hemoglobin. You should think of that oxygen carrying capacity of the hemoglobin will be diminished. Okay, so in the sickle cell, what is the problem actually? The problem is a vicious cycle. Like it cannot carry the oxygen very well. Whenever it is biconcave shape, it carries the oxygen very well. But whenever there is sickle shaped, it cannot carry the oxygen very well. So as a result, what happened? Tissue hypoxia. This hypoxia is the killer. Tissue hypoxia. So oxygen affinity is lower with the hemoglobin. So you need to think of that oxygen hemoglobin affinity will be lower for this size or shape, sickle shape, for this sickle shape. So sickle shape just causing decreased affinity of oxygen to the hemoglobin. You need to know this thing. As a result, what we are thinking, we should think about oxygen hemoglobin dissociation curve. There is some physiology in these things. That oxygen hemoglobin dissociation curve, there is something that is shift to left, shift to right. If you just go through the respiratory physiology, then you can also remember these things. But right now, I just want you all to just memorize these things. So oxygen hemoglobin dissociation curve, it will be shift to right during sickling. Because shift to right when the oxygen affinity lower oxygen affinity with the hemoglobin. Because you know that sickle shape could not carry more oxygen. There is low affinity. And as a result, tissue hypoxia happens. These things you need to know. And the details is in this description. So no need for the whole description. Just you need to know the low affinity of oxygen to the hemoglobin. So shift to right hemoglobin dissociation curve. Okay. So sometimes it came in the physiology and clinical science that in sickle cell disease, oxyhemoglobin dissociation curve where goes, it's shift to the right. Look how it happened, why there is some problem with the hypoxia as well as microthrombi formation. So microthrombi formation mostly look single base substitution causing some alteration of the shape, red cell shape. So we need to know only these things. And then it becomes sickling, like a moon. Microvascular blockage occurs because these sicklings causing clumping. There would be some microthrombi. Microthrombi, you can say the microthrombites. So we need to think of microthrombi here. As a result, there would be some cells, as they lose the shapes, there would be some intravascular hemolysis also, and then activation of platelets. So all of these things causes thrombosis, the obstruction of the blood supply. So segmental supply will be obscured. Look, here is the lungs. There is a lot of alveoli. So there are in the alveoli, there is a lot of supply of blood supply. So whenever these sickle cells are happening, hypoxia persists, as well as the blockage of these segments can be happening in the lungs. So blockage of these segments can cause hypoxia. So oxygen saturation decrease. As a result, chest pain, shortness of breath, all of these happen with fever also. So this is known as chest syndrome, acute chest syndrome, very, very important for the sickle cell disease. So number one for the chest syndrome, what? That is hypoxia. You need to give oxygen first. That's why you need to give oxygen first. In the treatment, you need to give oxygen. Because tissue hypoxia, you know the pathophysiology, tissue hypoxia is the main one. Tissue hypoxia shifts to the right. Because of shift to right, oxygen hemoglobin dissociation curve to the tissue, and then tissue hypoxia happens. So we need to think about tissue hypoxia, and we need to think about the complications of this sickle cell disease. Let's go. Here are a lot of sickle cell you can see. Mostly the area, this area happened in hemoglobinopathies. So what are the clinical features? These are the from the Davidson's. Clinical features can be ocular, pulmonary, CNS, cardiac. All of the things are here, but you cannot explain everything here. So you need to go for the precipitating factor and all the crisis. This would be easier than that week. So how it is precipitated, mainly aggravated by dehydration, hypoxia, acidosis, and any infection. So these are the things mostly. This can recycle the sickling, and sickling can causing aging hypoxia. So at the moment, patient gone to a vicious cycle of death, and patient go for death. So sickling persists with the hypoxia. The more hypoxia persists, more sickling occurs. So this is a vicious cycle, but we need to know the dehydration, hypoxia, acidosis, infection, and this aggravating factor. Okay, now most important is the crisis: vaso-occlusive crisis, acute syndrome, sequestration crisis, aplastic crisis, stroke, pulmonary hypertension, and other features. So one of the vaso-occlusive crises is acute chest syndrome. Most important is acute chest syndrome. There is blockage of segmental supply in the alveoli. This is acute chest syndrome. So some blockage occurs like infarction. So we can go for the description of acute chest syndrome. We need to diagnosis. We need to know the diagnosis of acute chest syndrome. So look, how it happens. Vaso-occlusive crisis mostly. Pain in hands and foot, dactylitis occurs. Pain in hand and foot, dactylitis occurs. Mesenteric ischemia can also occur. Avascular necrosis of femoral head. Okay, these things occurs. Pain in all over ribs and femurs also occurs. So these are the vaso-occlusive areas that can happen. And most important vaso-occlusive crisis is what? That is acute chest syndrome. So what happened to acute chest syndrome? Look, in the acute chest syndrome, you can see there is chest pain, fever, shortness of breath. And now we need to talk about the primary problem. Sickle cell disease, acute chest syndrome. That is, so acute chest syndrome primary problem is hypoxia. Why I am telling about repeatedly? Because the first line treatment of acute chest syndrome. First line treatment, high flow oxygen mask first, then IV fluid, IV painkiller, then IV antibiotics, then injective spirometry. And after that, if partial pressure oxygen cannot keep more than 70, IV support you can give, exchange transmission also at last. We need to go for. So step by step, 1, 2, 3, 4, 5, 6. These 6 steps you need to know step by step. So try to just locate the question that what is the initial treatment, what is the definitive treatment, what are the how we can give some painkillers, so what antibiotics we used, all these questions in the acute chest syndrome. So you need to just first pick up the sickle cell disease, then you need to pick up the chest complaints. So with the sickle cell disease, if there is any hypoxia present, any distress present, that is acute chest syndrome without any doubt. So first high flow oxygen, fluid and painkiller, then antibiotics, incentive spirometry. You can go for whether restrictive and obstructive present or not. Then if you have to not kept I2 support, then last accident transfusion. What is the prevention? Hydroxyurea is the prevention. How you can prevent this chest syndrome? Hydroxyurea by giving. It will increase the fetal hemoglobin, where the oxygen affinity with the hemoglobin increased. Actually, increased fetal hemoglobin will shift the oxidation curve to the left, because association of oxygen carry good oxygen, then it can release the oxygen very easily. So this is one kind of good effect, like Bohr effect and Helden effect, both of these in the tissues. So this, if you give hydroxyurea, then is hemoglobin fetal, then oxygenation will be good, hypoxia can be prevented. So prevention and treatment you need to know in the question scenario. Okay, so chest syndrome is like that, very easier thing. So I am going rapidly. Then sequestration crisis, like all of the sickling of the cells sequestrated to an organ, that is a spleen. So splenomegaly can be happen. Sometimes splenomegaly happen, and then low hemoglobin and hemolysis can occur. High reticulocyte count, recurrent, you can do for splenectomy. These two crises is very important. That is, one is aplastic and hemolytic crisis. Very rare, but aplastic crisis you should know all lineage low, like hemoglobin, WBC, and platelet. All are low. Pancytopenia with the reticulocyte count also low. So you should diagnose that. If reticulocyte count low, aplastic crisis. Okay. Hemolytic crisis is very easier, like hemolytic anemia, very rare. You should diagnose aplastic crisis and chest syndrome. These two are very important for MRCP. Okay, there are some tests, sickle dex test and also hemoglobin electrophoresis. You can find out the trait and also the hemoglobin SS. So these are the investigations we can do. Mostly you can do by reading the question. Okay, some complications can be happen, like nephrogenic diabetes insipidus. How you can diagnose diabetes insipidus? There are something you should diagnose diabetes insipidus only by plasma and urinary osmolarity. So for diabetes insipidus, you should be remember a law so that you can remember it, not to bias it. That plasma osmolarity is high after water deprivation, and urine osmolarity will be low. So high-low rule, you can apply high-low in diabetes insipidus. And in SIAD, excess ADH, where you can go for low-high rule. High-low and low-high. So whenever there is diabetes insipidus, you should think of plasma osmolarity should be high, urine osmolarity should be low. This law from the endocrine knowledge you should apply so that you can easily diagnose the diabetes insipidus. Because at the time of scenario, they will not tell that is diabetes insipidus. They will tell you polyuria polydipsia, patient having high plasma osmolarity, and low urine osmolarity or urine osmolarity. So by seeing this thing after water deprivation, you should diagnose this is diabetes insipidus. And if there is any sickle cell trait or any sickle cell question or any type of clue of sickle cell disease, you should think of that it is a question for the crisis. Like it affects the sickle cell disease, affect in endocrinology. You should know about lithium, you should know about hypokalemia, and you should also remember sickle cell disease. These three. In the other system, if you remember some kind of like this, you would remember these things for lifelong. That's why I'm telling in every part, the correlation part of another system, so that you can remember. Sickle cell disease, should remember for MRCP, nephrogenic diabetes insipidus, how you can, there is retinopathy, retinal artery occlusion detachment, can happen, pigment 40% patient having persistent erection, painful erection. So by this is one of the question, in the past test you can find it, priapism. A patient came to you, a sickle cell trait patient came to you with painful persistent erection. Within hour, what will you give, or what will you give to the patient? If there is any oral alpha agonist present, you can go for the oral alpha agonist, or urgent penile aspiration, intracorporeal alpha agonist injection. These are the treatments. So here I also mentioned the treatment also. So you can remember these things. Priapism, okay? So this is sickle cell disease, most important. And when you can give blood transfusion, just splenic sequestration and aplastic crisis, you can give some blood transfusion. So these are the indications and complications you should remember. So I would request all of you to just go for the nephrogenic diabetes insipidus also repeatedly. And also you should remember the salmonella osteomyelitis and priapism. These three things, mostly. You need to remember, okay? I will show you some questions so that you can understand. In case of exchange transfusion, sometimes there is a very important treatment for if any crisis and history of a stroke before emergency surgery. A patient of sickle cell disease need emergency surgery, you should go for exchange transfusion so that the sickle cells can be replaced by the normal cells. So in case of a stroke or in case of any emergency surgery.
জয়েন করতে করতেই 20 মিনিট লেগে গেল।
Okay, so now question is very important. One of you can just read it out, then you can make it. You can read it if you are free. Which of the following are associated with the condition? Can anyone read it, Doctor? Anyone? Those who are free can read the question only. Then I can guide him about sickle cell disease and some complications. Anyone? Dr. Ashish, Dr. Abhishek, anyone can read just?
Yes, sir.
Yes,
A
please.
22-year-old man presented with a 6-month history of fatigue, polyuria, and nocturia. He also reported a craving for very cold water. He had no past medical history. Examination was normal. Sodium is 150, potassium is 3.7, urea is 8.9, creatinine is 91, paired osmolality after fluid deprivation. The urine osmolality is 130, which is low. Serum plasma osmolality is 357. Which of the following are associated with this condition? Diabetes mellitus, MDMA abuse, pneumococcal pneumonia, porphyria, and sickle cell trait. Sickle cell.
Why? What is the diagnosis here actually?
Sir, diabetes insipidus.
Nephrogenic diabetes insipidus.
Yes. That's the thing. The high and low rule. The plasma osmolality or serum osmolality is high, and the urine is low. High-low. So high-low rule you should think of. In case of high-low rule, you should think of that is diabetes insipidus. So high was is plasma. You should remember that is plasma 1, so that you will not exchange it like that. Urine osmolality is low. So high-low, you will read plasma and urine. First there is plasma, then urine. So that's why first plasma you should put in your mind that then urine. So high-low rule is diabetes insipidus. Plasma would be high, urine would be low. So here the serum 357, this is high, and the urine, this is low. So high-low, in the high-low rule, you should think of diabetes insipidus. So paired osmolality after fluid deprivation, okay, diabetes insipidus, it could be cranial, could be nephrogenic, but there is most likely we have something that is related with nephrogenic, so it should be sickle cell trait. No other thing can cause such. Okay, so these things I just put because it is a lot of correlation over there. You need to just know that is, I have diagnosed the diabetes insipidus, then I have diagnosed the sickle cell trait. Okay, all right. Something that a patient with, if this patient suffering from pneumonia, like pneumonia, and somewhere there could be some chances that patient have hyponatremia, that sodium would be low, hypotension is high, and the plasma osmolarity is low. So low high, that is rule of low high. That is high low one thing and low high. So that is SIAD, syndrome of inappropriate ADH, no, SIAD. So hyponatremia, at that moment pneumonia would be the cause. So pneumonia at that moment, it is correlated with what? The endocrine test. So plasma osmolarity is low, low, high, then urine osmolarity. So on one way you should remember like high, low, high, so that you would not just that complexities would not be present during examination. So plasma osmolarity first you should read, then urine osmolarity. Low high rule is for SIAD, and high low rule is for diabetes insipidus. High low rule is for diabetes insipidus. Then you should correlate with the causes. Okay, I think this would be easier for all of the diagnosis. So let's go. Now we are on sickle cell trait. Here are the descriptions here: polyuria, polydipsia, sickle cell trait here.